Okay, good morning, everyone. Welcome to this webinar on the Roses in the Ocean policy paper, expanding the suicide prevention peer workforce. We have a fantastic panel of discussion to have with you today, and I'm going to introduce all of them in a moment. I will just start by acknowledging the traditional owners of the lands on which we're all gathering today, and pay my respects to elders past and present. I would also like to start by honouring the lives and contributions of people with lived experience of suicide, and acknowledge the very important contribution that you all make to suicide prevention. We have a range of fantastic panelists to discuss the new policy paper, which is available on the Roses in the Ocean website. Firstly, Dom Pizzuto currently works at Roses in the Ocean as a workshop facilitator and a mentor for the suicide prevention peer workforce. Dom has experience working as a suicide prevention peer worker and in coordination for both government and non-government sectors. They've experienced working with people in suicidal crisis, as well as those affected by suicide bereavement. Being both queer and gender fluid has given Dom an insight into how intersectionality shapes people's access to healthcare, and they're very happy to discuss that today as well. Mark Ellis is the National Services Lead for Suicide Prevention Peer Work Support Services for Roses in the Ocean. Mark has spent the last 30 years working in a variety of professional roles across the disability, aged care, community, schools, mental health and suicide prevention sectors, supporting people living with complex and enduring mental ill health, emotional distress and suicidal crisis. Caroline Allen is a suicide attempt survivor who continues to experience intense episodes of suicidal ideation. In 2015, she completed a psychology degree, graduating with first-class honours. Utilising her lived experience and academic training, Caroline is passionate about improving services for people who seek support regarding thoughts of suicide or who survive a suicide attempt. She has a particular interest in working with organisations to help them integrate trauma-informed practices into their services. And within her local health district, Caroline is a member of the Joint Regional Mental Health and Suicide Prevention Plan Steering Committee, the Towards Zero Suicides Lived Experience Advisory Group and the Consumer and Carer Council. In the past, she has worked closely with Lifeline Australia as a member of the steering committee for the Wellbeing Support Program and as an advisor in the rewriting of the crisis support worker training. Michael Cook is the Director of Service System Policy at the National Suicide Prevention Office. Michael leads the Service System Policy team, which develops advice and solutions to enhance service systems and diverse workforces that they depend upon. Michael's worked in dedicated suicide prevention roles for 7 years, including as implementation lead at the Black Dog Institute for the Lifespan Integrated Framework for Suicide Prevention and Towards Zero Suicides lead for the Sydney Local Health District. He also draws on experience as a psychologist working in correctional and alcohol and other drug settings, as well as providing sector project management and systems design. And Michael is passionate about using systems and policy levers to shift approaches to suicide prevention in Australia, aiming to improve our ability to better address the diverse drivers of distress through policy and service responses that prevent people from entering suicidal crisis. And my name is Stephen Scott. I'm the General Manager of Strategy and Policy at Roses in the Ocean. Now, I've asked our panellists to just consider a few key points that they wanted to discuss in reflection upon the new policy paper. The paper's available on the Roses in the Ocean website, of course, so please access and read it there. But Dom, I will go to you first. If you'd like to just kick off by mentioning a few of the key issues you wanted to raise in relation to the paper.
Cool, thanks, Stephen, and hello to everyone watching and here today. So in the paper, there were many points that resonated with me, but I'm going to talk about two today. The first one is around the point of how suicide prevention peer workers may not be at their peak effectiveness when they're working in mental health state-run organisations. Stephen raised this really important point in the paper, and from my experience, I think they're making much bigger impacts when they're deployed outside of government mental health services. So the paper touches on a point, on a fact that many people who are experiencing suicidal crisis may not ever access support through emergency or state mental health teams. This is for a number of reasons, but in part due to the fact that, of course, you don't need a mental health diagnosis to experience suicidal crisis. The research shows that it's commonly suicidal crisis as a result of situational stress from life events. So I just wanted to draw everyone's attention to a statistic in the paper that was quite staggering. It's about a regional Sydney LHD where they reported that in 2019, 80% of the people who died by suicide never accessed support through the state mental health system. And funnily enough, this was where I began my peer work career 2 years ago in this LHD. So I was working in crisis suicide prevention peer work in this district. And it's really important to note that this district is one of the highest immigrant refugee populations in Australia. So from this experience, we can draw the parallels between cultural and linguistic diversity and a lack of access to effective suicide prevention support. So the evidence comes from either statistics or lived experience research, but it points to that people who are experiencing suicidal crisis, who don't also have a mental health diagnosis and therefore don't need mental health treatment, are not choosing to access support through the state system, or if they do, they're reporting either poor or traumatic experiences sometimes. And this is really important to note that it only increases in marginalized groups where the rates of suicide are disproportionate. So intersections to consider here are people of colour, diverse abilities, neurodiversities, gender, and sexuality. So personally, I can speak from a perspective of being queer in my sexuality and fluid in my gender. So at any given time, I can identify as male, female, or neither. In suicidal crisis, I have and would never turn to the state system, as I just don't believe in their ability to safely support me and to understand my situation. So if I needed support, I would turn to QLife, for example, which is a peer-led LGBTQIA+ NGO support service. I want to make the point that I don't believe that all the state services are terrible at all. It's just that systems in Australia are usually designed to benefit white, heteronormative, and cisgendered men. And that's not to say that the system's perfect for men either, just that the chances of being seen and heard are higher than any other demographic. So the issue is that I'm sure that everyone's aware of is that health services suffer from a lack of effective cultural training, and there just isn't enough mandated time allocated within health to effectively train staff. And this is what I saw happen in this LHD that I talked about. Nurses, doctors, clinicians, especially in ED, in high-run energy situations, just don't have the energy to absorb any new ideas or innovative ideas. So that's not their fault. It's a system that's overworked. And it's also just not an environment where peer work can thrive because of that. So within state systems, there's also the inevitable structural forces that continue to perpetuate the systemic discrimination from the federal level. So this works to undermine the safe spaces for marginalized groups. So as the paper highlights, if people are in suicidal crisis and they're not choosing or using state mental health services, then it makes sense that suicide prevention peer workers need to be deployed to meet them where they're at in community. And this could be in peer-led community safe spaces or specialized NGOs. For example, Switchboard does really great work in providing LGBTQIA+ peer support to the LGBTQIA+ community in Victoria. So when I think about my professional work, I've experienced greater autonomy working as a peer worker outside of health in NGO teams. Where there's much less clinical oversight, number one, and the values and the principles of peer work were more valued, trusted, and had greater effect on the people that would be being supported. And this is because staff were trained in the effectiveness of lived experience support. And the lived experience lens was valued at all levels, including by employing lived experience workers in managerial roles. So to sum that up, there is an inherent mistrust in people, especially marginalized people, accessing services today. And this is due to the decades of mistreatment by government health services when it came to violating people's autonomy in the past with things like involuntary admissions, medication, etc. So for marginalized communities experiencing those disproportionate high rates of suicide, the health system isn't meeting their needs. They're not seen as safe, and it's going to take a long time to change and to heal. So in the meantime, to help fill the gap by government health, we can create better services outside of state and federal run organizations, services that are peer-led and that utilize peer workers of diverse identities who can connect to people in similar experiences of crisis. When this happens, I've seen results being transformational. So before I pass back to Stephen and on to the next speaker, I'm just going to touch briefly on the second point of the paper that really resonated to me. And that's the importance of the need for a standardized suicide prevention training for all suicide prevention peer workers. So currently there isn't an effective or consistent national training model available. And that means that peer workers are entering the industry with vastly different understandings of their role. So when I started my peer work, we were required to complete the Cert 4 in mental health peer work. And this qualification barely relates to the work that I did as a suicide prevention peer worker. So at the moment, I'm a facilitator for workshops for Roses in the Ocean. And one of the most common queries that I'm getting from participants is around the lack of a standardized, specialized training for suicide prevention peer workers. And that call doesn't just come from peer workers, but also the clinical team leaders around Victoria, New South Wales, within government and NGOs. So if peer workers are not equipped with consistent training, they're at risk of learning on the job. And with the current model of care in Australia being predominantly overseen by clinicians, this means peer workers mimicking clinical practice, which undermines what's so unique and effective about peer work. So we need to provide peer workers the space to practice peer work and an educational standard to give strength to our decision-making in our jobs. In this system, it's hard to validate the expertise of peer workers that in a system that's only designed to recognize clinical oversight and certified opinions. So a standardized training model will go a long way to solving that problem, I think. Thanks everyone for listening, and I'll pass back to you, Stephen.
Great, thank you, Dom. Some really fantastic points there. I would especially draw out the situational distress paradigm as being really crucial to the points we're making in this paper, as well as really the future of suicide prevention in Australia. That paradigm I think fits very neatly with the points you were raising about diverse populations and the need for peer support to be available on the terms of those populations, but importantly, outside of the mental health system and outside of that paradigm of an exclusive mental illness focus as well. The other point that you were making there is very much about that accessibility and availability point. The kinds of changes that we would like to see in suicide prevention from a lived experience of suicide perspective, and this is very much expressed in the paper, is peer support first and wherever possible, and clinical care only when necessary. And you know, I think as long as we are taking that mental illness focus rather than the situational distress focus, we're always going to put clinical care first and peer support as an adjunct or as a luxury item or an additional extra, if it's even available, of course, as well. And one of the important points made in the paper is that there is very large part of the Australian population that simply have no access to this kind of peer support currently at all. The final point you're making there about training, though, Dom, I think really neatly flows into some of the points that Mark was keen to raise as well. So, Mark, I'll go to you now at this point and ask you to discuss the issues you were looking to raise.
Great, thanks, Stephen, and hi, everyone. I've just got a couple of things that I'd like to add to the discussion. Essentially, I agree with the concept in the paper at point 1, a work environment that strongly supports both policy and operational senses of building, including at an executive level for its peer workers. However, I believe what's actually needed is probably more profound than the creation of a workplace culture that is conducive to the provision of the support required for its peers. As radical as this may sound, as a peer worker, I respectfully suggest that what is actually required is a total shift away from systems that are entrenched in the hierarchical medical model towards the establishment of inclusive workplace cultures that are supportive of the needs of all staff, regardless of their role, with the aim of the provision of person-centered care. I'd also like to draw your attention to a point that Dom was talking about, customised training in peer work and suicide. Firstly, there are currently no undergraduate degrees specifically for peer workers that would fill the current gap in certified study between Cert 4 and peer work and postgraduate studies in suicide. The development of a specific undergraduate degree needs to become a priority to ensure that peer workers have an appropriate course that extends their knowledge and skills as a peer worker. And this will also assist them in their professional development and facilitate recognition as a professional in the workplace. Secondly, I believe that a potential solution to developing the awareness of the value of peer workers within the workplace and within the multidisciplinary teams is to facilitate interaction between students studying peer work and those students studying allied courses at university. Thanks, Steve.
Thanks, Mark. There's I think some really visionary elements of what you've been describing there as well, especially the that change to the hierarchy or the stratification of different forms of expertise that we see in a lot of health systems and particularly in the mental health system in this case as well. There's definitely a big gap there in terms of the professional development and education needs as well. I think the point you make about that lack of tertiary training is really important as well, and a really critical area for further development of the suicide prevention peer workforce as well. We hope to come back to some of the points that Dom and Mark have been raising as well as we move on to Caroline and after that Michael as well, because there's a theme I think that is very much emerging around the system that needs to be focused on rather than just many more peer workers, although of course we are looking for there to be a significant expansion in the number of peer workers, but we also need to see that reorientation of services and the system reform that can go along to make those positions sustainable and for the people working in them to have positive professional experiences and to be well supported in a psychologically safe environment. Caroline, I'll go to you now. You're coming from quite a different perspective, I think, from Dom and Mark, who, of course, are drawing from that very practical experience they've had as peer workers and as analysts, I guess it's fair to say, of the peer work space in suicide prevention. You have been a long time advocate in the mental health and suicide prevention space, particularly as a consumer, as they're designated in the mental health world. I'd really like to just hand over to you now to hear your reflections on the paper and additional points that you'd like to raise.
Cool. Okay. I'm feeling really inferior now because you told me I didn't need to actually prepare anything, so I haven't. So you said this was going to be a conversation. So I'm just going to start talking, and if I run out of things to say, you'll have to ask me a question.
No problem.
But I guess something that just did pop into my brain when Mark was talking, and I'm curious to know what people think about this, is like when you mentioned, Mark, about peer workers having a university sort of pathway for education. In a way that feels tricky to me, because it almost feels like we're trying to get up on the level of clinicians, as though it's that hierarchy, as though you need a degree in order to legitimize what you do. And I can totally see why that would be a thought. As Stephen said at the start, I do have a psychology degree, and I find it quite ridiculous at times that I'll be talking to people and then they'll ask me if I have a degree or anything, and I say I have a psychology degree, and suddenly their whole way of speaking to me shifts, as though that makes me somehow a different person. And it really, really doesn't. My passion for this space, my knowledge, the things that I share, I didn't learn any of that through my psychology degree. Through my degree, I learned how to do inferential statistics, which is pretty useless. So I think that it's really tricky. Like, on the one hand, I can totally see why the peer workforce would want that degree pathway, because our society says if you've got a degree, that somehow makes you special. But on the flip side, from my lived experience of having a degree, I know it really doesn't make you special at all. So I think that is tricky. I don't know the answer to that. So yeah, that popped into my head. And are you going to ask me a question, Stephen? You're on mute. You're still on mute.
Are you able to hear me now? Yes, good, thank you. Mark, I just wondered if you wanted to comment further on the point that Caroline was raising there.
Yeah, sure. Definitely agree with what you're saying, Caroline, that a tertiary, university degree is not always what people need. I suppose the point I was really making was that if people are wanting to move towards, further study and understand peer work in more detail, potentially, a bachelor degree is required. And certainly if people have the goal of attaining a master's in something like suicidology, we need an appropriate degree rather than shifting into a clinical space and having more clinicians. As useful as clinicians are, we don't want more clinicians in this space. An alternative, or as Dom was pointing out, is that the existing training is subpar. It really doesn't address the needs of a peer worker. It doesn't help them understand the challenges that people face in real world terms. What it actually means when you're in suicidal and emotional distress, and how to aid those people. So.
And I think that's a super good point. That idea of people moving into clinical kind of degrees, if they want to sort of go through a degree pathway, I guess, because that is something that does bug me a little, that I've known quite a few peer workers who are doing peer work while working towards a psychology degree or a social work degree. And from my perspective, that feels like that's not then authentically peer work. It's kind of a fill-in thing on your way to getting a clinical thing. And I guess that segues into one of the points that really jumped out at me and that I was talking to Stephen about is that whole notion of peer drift. And I really struggle within the mental health system. So I've had numerous experiences in the mental health system, and I've met peer workers who, I've met peer workers who self-identify as clinicians, which to me just really hurts my brain, because it's like the whole idea of peer work is to be something radically different. So if you're ending up that you're trying to be a clinician, then you've kind of missed the point of what peer work is. So yeah, and I think that to me is one of the main reasons, like, that I think it is super important to have that suicide prevention peer workforce distinct from the mental health peer workforce, because again, it almost feels at times like I know some peer workers that have moved into that suicide prevention space, and it's almost like an add-on, that they're mental health peer workers and we'll just throw them in the suicide prevention space. And it seems to just be importing that clinical kind of mindset into the suicide prevention space, because, and I totally understand, like, there's no way I could be a peer worker, because I can see how hard it is in terms, like, certainly in the public system, of trying to hold on to those peer values and be accepted into the system. I can see why this peer drift happens, that rather than standing up and being something radically different, peer workers get enculturated into the clinical system. So to me, a suicide prevention peer work network needs to be radically different. It needs to start from the ground up. We can't simply be importing mental health peer workers into that suicide prevention space. That is my thinking.
I think that's a really key point of the whole paper there as well, Caroline, that the tendency that we've seen, I think, from state systems has been to simply kind of roll suicide prevention into mental health, including into mental health peer work as that kind of add-on that you were describing. And, you know, we also see this very much in the Cert 4 qualification as well, where there's a suicide prevention elective, which, you know, may or may not be included in the, you know, in the actual units that a person completes in order to obtain that Cert 4 as well. So we're really looking for integrated systems by all means, but also the specificity of suicide prevention in peer work as well. Dom, I just wanted to go back to you briefly there as well, because I think this concept of peer drift that Caroline referred to also touched on some of the points you were making about that kind of co-opting of lived experience or peer work perspectives into a clinical paradigm. And I just wondered if you wanted to expand on that at all.
Yeah, for sure. It's something that I noticed, and I think what I mentioned around a lack of training for peer workers before they start, and then an ongoing training to help them steer into clinical or mimicking clinicians, but stay in the peer work space. I think that's crucial so that this peer drift doesn't happen. If it is to happen, if peer workers are working in state systems, but I think that's why I drive the point home that perhaps state mental health systems or state systems are not the best place for peer workers because of the culture that is going to take a long time to change.
Yeah, thank you. I think at this point it might be just good to bring Michael in. We will go back to you, Caroline, though, because I know you've got many more observations that you could contribute as well. But Michael, you're again also coming from a unique perspective on this issue, coming from the National Suicide Prevention Office. And I wondered if you'd like to make a few points particularly given the workforce development activities that's on, I know is on the office's agenda, and of course the development of the new national strategy as well.
Fantastic, thank you, Stephen. So I might, if it's okay, start with just a little bit of brief context about the role of the NSPO, because it might, as a new agency, we might not be familiar to everyone on this webinar, but also I think because of its origins very much connect with some of the opening comments from this discussion, and in recognition of a few points, like the fact that the drivers of suicidality are diverse, spanning interpersonal, economic, legal, health, trauma, and a range of other situational stresses. That experiences of mental ill health are a common contributor, but not a factor for everyone, and are rarely a sole driver of distress. And that ultimately that leads to the conclusion that if we are to significantly reduce suicide rates, a distinct approach is required that expands beyond the mental health system and the health system more broadly, and necessitates actions from, in fact, all parts and all levels of government. So government has recognised this reality, and so the NSPO has been established to work across different portfolios at a federal government level, as well as with state and territory governments to help them to work collectively, ultimately, to reduce suicide in a consistent and coordinated way. So really embracing that national picture. I think it's worth as well sharing a bit about the vision that we're aiming for. And it's, I guess, a little bit broader and deliberately so than traditionally the realm of suicide prevention efforts in the country. So, you know, our vision is one for a culture and society that is safe and inclusive, where the risk factors for suicide and suicidality are reduced as much as possible, and where everyone can get individualized care that is responsive to their individual needs and circumstances. And I guess the key thing there is, it's not just responsivity for people who may be experiencing distress, but it's very much moving well upstream to acknowledging government's role in providing a society that assists people in thriving in the first place, and then works back to provide support mechanisms from that point. So this means we've got a pretty big remit, a pretty big lengthy to-do list, and the first piece of work on that list is a national suicide prevention strategy, which aims to articulate a unified vision for what an effective suicide prevention system looks like, and provide clear direction to government so that they can coordinate efforts to make that a reality. We have published a scoping paper late last year that kind of lays out the initial thinking on that strategy. Has received broad endorsement. So that's acting as a bit of our starting point. But essentially, if you boil that all down, we're trying to move things in two directions. One, as I've already touched on, is that a significant expansion of what the suicide prevention system looks like to encompass more upstream efforts and genuine prevention. So recognising the opportunity and the need to build protective factors at a community level, build a baseline of well-being, as well as acknowledging government and the broader community's role in reducing the prevalence and impact of common drivers of suicidal distress. And then the other direction that's a particular focus for us is broadening the ability of our care system to respond to diverse and often co-occurring drivers of distress, that in a way that is responsive to the individual needs, as I've touched on. So really they're kind of two directions that we're trying to press. And that's where this paper presents a compelling argument for the benefits, the potential benefits for the entire system, that the entire system stands to gain through the expansion of the suicide prevention peer workforce, not least of which are opportunities to help address the immense workforce strain and the fact that our entire system does not have the capacity at the moment to respond in the way that I think we all recognise it needs to. But it's also the ability of an expanding peer workforce to champion new models of care, as we've touched on, that expands beyond where our current infrastructure resides, predominantly in mental health and public mental health systems, as well as improved ways of working across these established parts of our care infrastructure. I think it's worth thinking about the the opportunities that the peer workforce represents, both in terms of the direct impact to people that that we're aiming to support, but also in influencing how the system itself operates. So it's important not to lose track of that as well. The work that we've been doing on the national strategy so far recognises these challenges and opportunities and sees the expansion of the peer workforce as a priority. We have also recognised the need to focus in on the topic of the suicide prevention workforce more broadly as a critical foundation for any progress. The workforce as a challenge across the entire system at the moment would not be a surprise to anyone. So we're also committed to, as once we deliver the national suicide prevention strategy, we'll actually have a dedicated national suicide prevention workforce strategy, for which the peer workforce is, going to be a huge focus. So the question essentially for us is not whether the expansion of the peer workforce should be a priority. It absolutely is. It's more about centering on what needs to be in place to best support this growth and create the conditions in which the entire system and the people it supports can derive maximum benefit from what the peer workforce has to offer. So for us, and this is obviously our work is in progress at the moment. So we're very much in that kind of listening and understanding phase, so we can, hone in on specific actions. But I guess important factors that we recognise are, creating an environment and culture across our service system that recognises the value of the peer workforce and empowers peers to work to the top of scope, providing pathways that attract people to the profession, provides the appropriate training, supervision, mentorship, and continued capability building, as others have already spoken to, that supports and retains them, and strengthening guidance and expectations for the integration of the peer workforce across clinical, non-clinical, and obviously peer-led components of our care system. So that's just a bit about where our thinking is at the moment, and I guess, painting that focus on, okay, what are the mechanisms that we should be prioritising at this stage in the journey of the expansion of the suicide prevention peer workforce.
Well, thank you, Michael. It's been a really informative overview of where we're intersecting with all of the policy work going on at the moment. Caroline, Michael referred there to expanding our concept of the care system, and one of the points that is emphasised in the paper is the location of these peer workers and the accessibility of them. One of the concerns we have is that to access peer support in many settings where they are currently available, you need to have made a suicide attempt in order to gain peer support through aftercare where that might be available, or you need to access clinical care first in order to reach peer support as an adjunct to that clinical care. There's a lot of movement or discussion, at least, around the need for more non-clinical services, and I know this is also something that you've been strongly involved in. So I wondered if you also had some reflections to make on those points.
Yeah, to me that is one of the massive issues. So I'm someone I identify as a survivor of mental health services. I have massive trauma issues due to experiences within the mental health system. So I'm one of those people that would now never reach out to ED or present at the hospital when in suicidal crisis. And for me, that also extends to, I won't go to any sort of clinical service, and I won't go to any service unless I could be 100% sure that they're not going to call 000 on me. And thus far in my region, I haven't been able to find that. So it puts me in the position I don't reach out to any services. So my dream would be to have a genuinely non-clinical kind of service that was fully peer run, and where I could be confident that those peer workers were authentically peer workers. So again, like I know of instances where peer workers have called emergency services on people. So again, from my perspective, that is not authentic peerness, I guess. So to me, that is a passion, that to find that authentic peer space where you can go when you are in extreme crisis and know that someone's going to be there and be fully present and isn't going to flip out and call 000. So if we can just make that happen, that would be super.
I think that's really eloquently put. Those are exactly the types of services that we need to see, many more of around the country. Unfortunately, at the moment, there's they are rare, those types of services, and there's many people across the country that would really value having access to those that currently don't. So you're right, it's a massive gap in our system. Which, if addressed, would really meet the needs of many people that aren't being well served by the current arrangements. Mark, I might just go back to you briefly here, because we talked a bit about training, and Michael was also referring there to the support structures that are needed to sustain peer workers in their role. Roses in the Ocean does have a suicide prevention peer work training curriculum, but also a support service, which is provided as well, which is quite innovative, but I think points to the types of support that are needed by suicide prevention peer workers. Could you just refer briefly to what that support system looks like, separate to the training curriculum?
Sure. Essentially what it is, the workplaces that employ peer workers, and this is not always local health districts, many of the mentors, many of the peers that are being mentored are from NGOs. They have the option of utilising a monthly to 6 weekly mentoring service, which is a one-on-one, generally, held online. It's totally confidential. They can discuss what they need. They can bring the issues that are relevant to them. It could be a particular scenario with someone they're working with. It could be a workplace issue, professional development sort of thing they want to talk over. The important aspect of that is that they can talk safely to somebody who is a peer worker and is outside of the system that they're actually working within. So, to really be able to debrief and problem solve and, look at potential options, to identify potential options, or to assist them to identify potential options. The other element that we have that peer workers can access is co-reflection sessions. So as a team, if they want to engage in that, people, between 6 and 12 people can meet online, and essentially it's probably the best way for me to describe it is it's like a collective brains trust. So if somebody brings an issue to the session, everybody can, think laterally about the concern and make suggestions. So they both work really effectively, and peer workers feel incredibly supported. It goes above and beyond, the traditional support and supervision. You can't open up, as a peer worker, you can't open up to your line manager about a concern you have. So that's one of the major challenges as a peer worker within a system, regardless of where you work, whether that's a health system or an NGO,
Yeah, and I think this is a really crucial part of the whole picture, isn't it? As I mentioned earlier, it's not simply the proliferation of more suicide prevention peer worker positions. It's also about the support structures, the system reform that needs to be put in place or pursued in order for that expansion of peer worker roles to be really effective. And you've mentioned there, you know, the management improvements that are needed, as well as the external support and professional development that's needed as well. So it really is a whole package of reform that's required.
Yeah. The other thing I'd add to that, which I didn't speak to, is it's totally confidential. You know, what happens in the session stays in the sessions. Nothing, you know, right down to, you know, the taking of session notes, completely confidential.
Yeah, thank you, Mark. I think there's some really excellent examples there of the types of support or the environmental conditions that are needed for peer workers to be sustained in their roles. We are just about out of time, so I would just like to take the opportunity now to thank our 4 panelists for your contributions. Really very insightful comments, and I think the viewers of this webinar would be able to see that there's certainly a lot of dynamism in the policy space going on right now, and a lot of important opportunities for us to see the strategic moves that are necessary for us to really build this community-based non-clinical support that we need to really see so much more of in suicide prevention. Just to conclude, the policy paper itself, as I mentioned, is available on the Roses in the Ocean website. We will be engaging in a lot more advocacy around this paper and the content of it with government and the suicide prevention sector over the coming months. We are also planning some further online discussions and some social media activities around this issue of expanding the suicide prevention peer workforce over the coming months as well. So please keep your eyes peeled for those upcoming activities and events as well. But for now, thank you again to our panelists, and thank you to all of our participants and viewers today as well. Have a great day, and we will see you again soon. Thank you, everyone.